practical aspect. Every midwife would like to handle the breech, and you should do it in confidence. You should be able to deliver the breech without the breech sustaining the slightest fracture or the mother having any complication, even though they are bound to come. But you can still safeguard against it. So please, let's start there. Listen, I think the last time, for the sake of those who decided not to attend lectures last week, I'm not going over it, but I'm just mentioning the points that we have treated so far, so that at least we have mentioned 2 types of breach already. We said the complete breach, the incomplete breach. And it is the incomplete breach that we have 3 types. We have the footling, the frank breach, and then the kneeling. So in general, we have 2 types of breach, but 3 types under incomplete breach. For the sake of those who were into, so that they can also go over it. We also mentioned that another name for breach presentation is podalic presentation. Another name for breach presentation is podalic presentation. We mentioned that why there's the need for us to do what we call external cephalic version. Why do we have to turn the baby for the head to come down? It is a procedure that has to be done by the doctors, but midwives also do it in a situation when it is oblique lie. Then you can do that. Other than that, you have to conduct the breech delivery. Then we came to how to diagnose breech during the ANC. We mentioned a lot how you can palpate the buttocks at the lower pole of the uterus. You palpate the head at the upper pole of the uterus. And then we also said that we cannot confirm breech until the 32nd week of gestation. Please, are we together? Can you hear me? Can I continue?
Yes, please.
Yes, please. I'm only making a summary of what we did last week, the previous weeks. And so we also came up with how to diagnose it, as I said, during the antenatal clinic. We said it. And then we talked about the positions. In the antenatal, we said a lot. But then when it comes to the diagnosis on vaginal examination, that is where my concern lies. On vaginal examination, how we'll be able to differentiate footling if it is the feet, not the foot. Normally it's 1 foot that presents. If it is the foot that is presenting, how you'll be able to differentiate it between hands, the fingers. We say the fingers are longer, the thumb is far away from the rest of the 4 fingers. If it is the hand that the baby is using to present, and that one will come about as a result of compound presentation. And then we also said that if it is footling presentation, then we should know that the big thumb cannot be separated from the rest of the toes. And that is a sign that it is the foot that the baby is presenting. We also mentioned that if it is the foot, you can feel the sole of the baby that is narrow. It narrows, and then it is also long. And then there's a heel bone. You can feel the calcaneus, that is the heel bone. You can feel it when you do vaginal examination, especially when the membranes have ruptured. Membranes rupture early because of ill-fitting presenting parts of the breech to the cervix. And so membranes will rupture early enough. And so don't rush and go and rupture the membrane, because spontaneously it will rupture before even the baby or the woman gets to the second stage of labor. And then we also mentioned we did mechanism of right sacral anterior. We did mechanism of right. Whoever is making the noise. Now I've been given the chance to mute or put you in the waiting room. I don't want to do that. So just conclude your talk. Let me identify the person. Evelyn Mensa Ankwa. Evelyn, please mute yourself. Elinosu Mensa, mute yourself, please. Breech is very, very important in midwifery. I don't think you yourself will feel comfortable when you deliver breech and then give a dead baby to the mother. The relatives go and bury the baby. it's the fault of the midwife. And it shouldn't happen that way because you can guide against it. So please don't do that and pay attention. And then we talked about restitution of when the movement begins. We said the baby, the sacrum being the leading part, will meet the resistance of the pelvic floor muscle, then rotate 1/8 of a circle, then come to lie under the symphysis pubis, where there will be internal rotation of the buttocks. Then it came to the delivery of the head. We said a whole lot about the delivery of the head. We are still under the movement between the baby. Vivian, okay, maybe I can, if I can put Sally for Ashika. So please, just listen. If you think we are not interested in the bridge, for the sake of a poor mother in the rural area who will need your services, just listen. One day you will come face to face with bridge presentation. So please, I beg you, listen to me. And then we also talked about delivery of the head. We said occasionally, if it is left hospital in the, how do you call it? If the head enters the brim of the pelvis, in the transverse diameter, normally occasionally it will rotate to the left oblique diameter. And then if the head is well flexed, then the suboccipital of 9.5 will engage. And then if it is incomplete flexion, please take note of this sentence because it is there in my question. If it is incomplete flexion where the head has extended, then it is the suboccipitofrontal diameter that will engage. Please take note of that. Before rotation will take place for the baby to rotate and then come out. Now, let's see how we can manage the baby, the management. But before we come to the management, we said there's a reason why we have to perform cephalic version. I gave us so many points. Can somebody just summarize the reason why we can perform cephalic version? Give us just 3 or 4 reasons why we have to be about 10 of them. There are about 10 of them. Please, if you have an idea, raise your hand. And then we came to the contraindication. Just mention 4. It's a summary that we are doing. So somebody should mention the one who was talking. Let me see if I can remember the name. And you see, they have started running away. Abigail Gbogbo. You are not the one who was talking. I'm only calling your name. Abigail, give me 2 reasons why you think we have to do external cephalic version so that the baby will be delivered by the cephalic instead of the bridge. Just 2 reasons. Yes, Bridget Kudom. Bridget, go ahead.
Sister, in cases of oblique or transverse lie, external cephalic version is done.
Okay. Any other? Thank you. Any other? The major points that we mentioned. Hello? Oh, please, I want to see more hands. Oh, you didn't go through your notes. You have the slides, so you can go through them, please. Catherine Davo. Catherine, mention just 2 reasons why you think cephalic version can be done and deliver the baby by cephalic instead of the bridge. There are so many, there are numerous of them. So that in your quiz, the next quiz, if I ask you to list just 10 reasons why cephalic version is encouraged, you should be able to list them. That may be your midterm exam. So please contribute so that I know you do understand. Yes, Esther Kua.
Okay, sister. So in case of PPH, external cephalic version is done. PPH.
In case of what?
Postpartum hemorrhage.
Postpartum hemorrhage, it means the baby has been born already. And if it is rather, if it is because she's bleeding, Placenta, part of it has separated in utero. And that is why she's bleeding. So you don't attempt. That one will come under contraindication. But we had a fear that there's nerve damage. Have you forgotten? We said because a breach is associated with complications like fractures, nerve damages, muscle injuries, bruises. Oh, we mentioned a lot. Yes, Hester, now come up with your own. I've mentioned just a few of them. So come up with your own.
Hello,
yes. Hello, dear.
We also said there could be intracranial injury.
Very good.
That's why we do cephalic version.
Exactly. Thank you very much. Any other? Any other that you can think of?
Yes, sister.
Say it, dear.
Spinal cord fracture or fracture of the spine.
Great. Because you are afraid that the baby may end up with spinal fracture or a nipping of the cord, cutting off blood supply to the fetus. And that's why you don't want to try the breach. And so you want to do cephalic version. Yes, any other? Yes, I'm happy to see more hands. Yes.
Mama,
go ahead,
fetal distress.
It is associated with
fetal distress.
Yes, I agree with you. Thank you.
Yes.
Fetal distress, because we are worried is that if this baby is born by a breach, it may be asphyxiated or there may be intracranial, pressure causing distress or anopsia. Anopsia can occur, bringing about the fetal hypoxia. Good. Any other?
Hello, Aja.
Yes, madam.
Please, there could also be premature separation.
Rupture of the internal organ. I think two people answered at the same time, but I heard rupture of internal organ, which is true. The baby, you, the midwife, if you don't know, if you are not well versed with the delivery of the baby, that is where you will allow the baby's abdomen to face up, to point at the symphysis pubis instead of the spine, the back, pointing to the symphysis pubis. Some midwife will conduct the delivery, a baby's abdomen is uppermost. You do that and you will rupture the spleen, you rupture the, the liver, and the soft organs in the baby's abdomen are likely to damage. So you deliver the baby, and it is dead. So for that fear, we say, let's do external cephalic version. Thank you very much. Thank you very much. Let's listen to Anita Santi, then we can continue. Anita.
Yes, there could be intracranial hemorrhage for the baby.
There could be intracranial hemorrhage, especially when the head is delayed in coming. So these are the reasons why we want to do external cephalic version. Okay, contraindications for version. Why wouldn't you like to do a version? We have mentioned two reasons already. Why wouldn't you like to do external cephalic version? In cases of breech presentation. Mention them. Yes, Selena.
Hello,
Selena.
Ajia.
Yes, Selena.
Yes, when external cephalic version is done for someone with antepartum hemorrhage, it's not advisable. So it's an
it's a contraindication. Why?
Contraindication. Because there is a possibility that the placenta may detach before even the baby comes out, and the baby may die.
Clap for yourself. You yourself clap for yourself. So that is the reason why it is Fatao, I'm putting you in the dark room. I'm going to put you in the waiting room. Are you ready to go there? Fatao, I'll put you in the waiting room. Do you want to be there? Or you will discipline yourself by keeping quiet? Okay, please, I can see many hands. Mariam Musa. Mariam. Yes. Yes, please. Go ahead. Placenta. No, did you say placenta previa? Placenta abrosiorata. A contraindication. Okay, contraindication. Yes, in cases of placenta previa, you don't attempt good. And even with the previa, irrespective of the type, you don't even encourage that kind of version. That is true. Thank you. Yes, any other? I'm happy. To the many hands, it tells me that you are learning. Let me see this name. Mavis Haba. Oh, Mavis, your hand is up. I wanted to call your name and you are running away. Mavis
No, I'm holding.
Habamua. How do you pronounce this? Habanmua.
Yes, Hagba.
Okay, I've done well. Okay, so why wouldn't you like to do version?
In cases of multiple pregnancies.
In cases of multiple pregnancy, because you make an attempt to form the first one, and then the second one in the process. It's why?
Struggle some.
I wanted to look. What you have paid money. You have paid money. You want to do first degree, and this is how you are doing it. Can you tell your husband or boyfriend to stop that, and so that all that you are doing is outside?
Abiba too. Yeah, it's the woken in a
Serious.
Fatawa people, you have disgraced yourself.
Like,
It's shameful. Abiba Fatawa, whoever knows her, call her that she is disgracing herself. Okay. So that is all about the contraindication. We said a dead fetus, you can't do external version. In cases of essential hypertension, you don't have to do version. Shall we quickly, did we go through the procedure for version? Hello, ladies and gentlemen. Did we go through Yes, we went through it. Okay, somebody should make a summary of it for me. Mariam Musa Bwedi. Mariam, how do we do the method of version so that quickly we can deliver this baby before it gets asphyxiated? Yes. Hello. Oforu Amankwa. Beautiful name. Oforu Amankwa. Adams Rahima. Rama. Adams Rama, tell me, how do you do the version? Quick one. Why are you people running away? Somebody should tell us, please. I'm talking plenty. Yes, Adams Rama. Rama, your hand is up, so go ahead. Okay, so talking about the method of version, we said first we have to do CT scan to confirm that it is breech delivery. I mean, it is breech presentation. And then the midwife will have to collect the film, and then you have to observe it. The doctor will also inspect it before you start the maneuver or the procedure. The midwife will have to tell the woman to empty her bladder. And then the procedure, explain to her, reassure her that she's in safe hands of a good midwife, a competent doctor, a competent midwife. Then the woman lies in the dorsal position with the head raised on a small pillow. Then you note the position of the fetus. Sometimes, in some cases, you can even use bed blocks to raise the foot end of the bed. But some scholars are also saying that it is not good. Other than that, the baby will exert pressure, the head will exert pressure on the diaphragm, and the woman may go into distress. So the bed blocks, there are two schools of thoughts. Hello, are we together? Can I continue?
Yes,
Yes,
sister.
Yes.
Okay. Very good. Okay. Then we are saying that you, the midwife, your responsibility is to do abdominal palpation. Then you listen. You know, abdominal palpation has the, what do you call it? Abdominal palpation goes with three things. IPA, inspection, palpation, auscultation. That's the IPA, I've named it. So that you do that for the doctor who is coming to do the version. Then the doctor or the midwife who does it will just warm her hands. You put some smooth powder on the abdomen just to facilitate the movement. If you have the gel enough, no, the gel is a little bit expensive, but powder is not expensive. So you sprinkle it on the abdomen, then you start the procedure. You palpate to locate the fetal head. Very, very important. Palpate to locate the fetal head with one hand on one side, then gently, the midwife or the doctor gently moves the head of the fetus to one flank of the abdomen. Gently, you are moving the head gradually. It's not an overnight thing. It should be a gradual process. You move it to one side. Then with the other hand, he tries to lift the breech. So as one hand is moving the head to one side of the abdomen, the one hand is also lifting or moving the breech into the opposite side, into the opposite flank of the abdomen. Then you make sure that you maintain flexion of the baby by allowing the fetal head to follow its nose. Allow the fetal head to follow its nose. So it's like you have grasped the occipital area of the baby's head. You are moving it downwards, and you are moving to the other side. If it is at the left side of the mother, you are moving it to the right side of the mother, but then you are following the nose of the baby. We are following the nose because if you don't follow the nose, there's something we call it. That's this thing that I'm going to say it is also in your objectives. Other than that, you cause what we call bootstrap rupture. Bootstrap rupture. If you don't follow the nose, the bridge of the nose can cause posterior laceration of the uterus. And so it's like you rupture the uterus by the bridge of the nose, of the baby's nose. Before even you complete the version, patient will start bleeding. You have already ruptured the uterus. So you see, that is how it has to be done. So you move a little bit, then you stop. You move a little bit, then you stop. Then as you do it, we are saying that if you find out that it is too painful for the mother, please, you have to stop the maneuver. When you realize that patient is complaining, see, I'm in pain, it's paining me, please stop the procedure. Other than that, it shouldn't be a painful procedure because the lycoamina is there. It is facilitating the movement. And so why should patient feel pain? It shouldn't be any pain. Unless it is contraction. Unless there's contraction. And if there's contraction, you stop. Then as you do it, you examine the vulva for bleeding or lycoamina. Probably the membranes have ruptured. Then you wait for pain. This is the second time I'm talking about watching for pain. And then premature onset of labor. You observe if there's premature onset of labor, then you have to stop. Then you record the time that the procedure started and the time that it will end. You ask the patient to lie down at least for 2 hours after the procedure. And then you observe the patient keenly. The woman will be asked to go home and report after 1 week for checkup. And then if she comes after 1 week, if she sees, or before 1 week, if she sees anything that is abnormal to her, she should come back and report to you. She's also advised to deliver at the hospital if the breach persists. You watch out for tense abdomen or intrauterine bleeding. Watch for all these things before the worst thing happens to the woman. So that is how the maneuver is done. External cephalic version, that is how it is done. Please, any question? Do you have any question for me? Can I continue? I'm asking you, please, I can't see your faces. So if I ask a question and there's nobody answering, when I ask the question, please, if you know you have an idea or you want to respond, you unmute yourself and respond. Okay.
Please question.
Ask your question, madam. Ask.
Okay. So please, with the version on the abdomen, I didn't. I don't know if you mentioned it. I didn't. Do you put any gel on the abdomen or nothing?
Who heard me and can reply her for me?
Please, she said either gel or powder. Because gel is expensive, you can use the powder, which is expensive.
Thank you.
Okay, so I said it. Okay, that's good.
Please, Hajia, is oligohydramnios a contraindication for the cephalic version?
Yes, oligohydramnios. Yes, it's contraindication. I'm coming to mention them. When the amniotic fluid is scanty, you don't go ahead and do the version because even it wouldn't facilitate. It will rather promote placenta separation. So oligo, you don't do it. And polyhydramnios, you don't do it because it wouldn't be stable. The amniotic fluid is plenty. You do the version, oh, maybe we'll go back to his position, go and enjoy the position over there. It wouldn't retain as you want it. So in both situations, you don't do version. So let's see the contraindications of version. Premature onset of labor. If a patient is having, I'm talking about complications of version. Complications of version, you can have premature onset of labor. You can also have premature separation of placenta, that is placenta abruptio. And then there can also be premature rupture of membranes that can cause prolapse of the cord. There's also the possibility of true knots. In your attempt to move the baby to the other right or left side of the uterus, you are likely to cause true knot. And we all know that true knot can lead to fresh SB. It can bring about fresh SB. Stillbirth, baby will not show sign of life. Because as you are doing, then the cord is tightening. It is tightening, then it will cut off blood supply from the placenta side to the fetus, and you lose the baby. So that is one complication that can result. And then there's also the possibility of uterine rupture. If it is too much, if the midwife or the doctor exerts too much pressure, it can cause the uterus to rupture. I've ever witnessed that before when I was in the labor ward. I've ever seen the doctor wanted to do, that's why in fact it was internal cephalic, the internal CODeL version. The first twin came, the second twin was transverse. She managed to bring it to breech, and the doctor wanted to deliver the baby by breech. So he gets hold of the leg, and the baby it will slip. It will slip from the hands of the doctor. This doctor said, "No way, I won't do CS." He kept on doing it. The patient was shouting. The woman was crying, shouting, "Doctor, who come me? Doctor, you are killing me. Please, you are killing me. I'm in pain." Doctor wouldn't mind. And so patient started bleeding profusely. So the doctor suspected that he might have ruptured the woman's uterus. Lo and behold, went and opened, did CS to remove the live baby. There were two boys. Removed the baby, and then the uterus has ruptured beyond repair. And so he has to do hysterectomy. So the doctor did hysterectomy for that tumor. I will never forget this scene. It was so pathetic. They did hysterectomy, and so that was the two boys he had. The last time I met her sister, he said, "Oh, those boys, they have even completed university." That was the only this set of twins that she had. So that is a complication of version. Now, let's manage the woman during the first stage of labor. Please, the management of a patient. Any question? So I can see some people's hands up. Awin Zonga. Bridget Kubum, do you have a
Hello,
question?
hello, hello, Adrian.
Yes, go ahead.
Please, I want to ask a question concerning the mother's side. Whether if in case of if the mother has pregnancy-induced hypertension, can you do the cephalic version for that mother?
No, please. No, please. Sandra, Sandra, mute
What
your
of
children.
previous years? Someone who has the previous years, and then
you don't
the
do
baby
you don't do the version. You are likely to rupture the uterus through the old scar. So previous years you don't do version. It's contraindicatory. I think we mentioned the contraindications. So we mentioned them all. Okay. So let's see the management of breech presentation, the principles of management during the first stage of labor. Please, we are going to brainstorm because the management is not different from the management of a client during labor in a normal cephalic version. It is not different. So let's brainstorm and then quickly finish with the management of the principles of management of breech presentation during the first stage of labor. Whose hand is up? Hanifa Ankra. This name sounds familiar. Hanifa Brago. Tell us, what is the money? How would you manage a client with breech presentation during the first stage of labor? The general management of first stage of labor. Hanifa, tell us. Don't tell me you don't have anything in mind. You have. Hello. Oh, Hanifa, your hand is up, so we are waiting for you. Don't waste time. Or anybody, you have managed patients during the first stage of labor before. When we're dealing with normal labor, I took my time, we brainstormed beautifully. Why is it that this time you don't want to raise your hands? So, yes. Okay, then that is your assignment. Go and read on it. Go and read on the management. If you are not ready to share your ideas, then please go and read on it, okay? Are you trying to tell me that you don't know the management of first stage of labor? Then I'm happy I've gotten a question that I can
please, I'll try.
Go ahead. Come to the papers and spam a more mature at it is a poto.
Okay.
Okay.
The management of breech labor is not quite different from the SVD. So you prepare, if you confirm if the dilatation is full, then you prepare a set.
Hi. Did you say that? Did anybody hear her? No, they didn't hear you. And I don't want them to hear that. They didn't hear that. I also didn't hear it. That you are managing first stage of labor and you're going to do vaginal examination.
I thought you said second stage.
Hey, oh boy. Oh boy. I said management during the first stage of labor. I said second stage of labor.
I thought you said second stage. That was why I'm talking about it.
Oh, okay. It's first stage. So go ahead with the first stage.
So with the first stage of labor, if the woman comes, it's more like the management of the normal cephalic delivery. But with this one, even though every client needs to be extra careful and then always pay attention, but this one, the rate at which you'll be checking your fetal heart rate and your contraction you'll be checking it frequently, and then
Okay, thank you very much. Yes, who is Christian Addison?
Hajia, please, the management of the first stage of labor, it's not different, just as some of my colleagues had already said. So we will use the acronym you taught us in normal labor, the HOMIP.
Yes.
So we will establish rapport just as the client reports. We will do the admission process. We will take history, we will prove further. When did labor start? Has memory ruptured? What was the color? We prove further. We will observe the observation. From there, we will do the examination. That will be either abnormally or vaginally. Then we will do the management, that is the actual management. If we see the patient, maybe the patient needs IV fluid, we will administer IV fluids to keep the patient hydrated. We will do laboratory investigation and we will prepare towards the second stage. Thank you.
Thank you very much. What's your name?
Christina Addison.
You see, I'm so grateful. Thank you very much. Anything to be added? Thank you very much. Anything to be added? Bridget Kudoma, can see your hand up.
Hadia, please, I'm not adding. I had a question, but when you called me, my network took me off.
And okay, what was your question?
I wanted to know if back then they were using Trendelisberg position in external cephalic version, because you only mentioned the dorsal. I wanted to know, like in my notes from Nelson, it was Trendelisberg. So I want to know if that was used before or something.
The bed that can help you to put the patient in the Trendelisberg position. How many facilities have that bed that you can throw and turn the patient into that position? Because you don't have that bed, unless maybe you want to take the patient to theater where they might have that bed, and then put the patient in that position, and then you can go ahead. Other than that, it is on an ordinary bed, you can do it. And I mentioned that even lifting the legs or the lower portion of the patient, researchers are saying that if you do that, the baby can be thrown to the upper part of the abdomen. Already the head is there, then it will be pressing on the diaphragm. Even when I was explaining this, and I just said it, and the woman may get difficulty in breathing. And so you let the patient be in the dorsal position to be on the safer side. Is that okay? Mm-hmm. Okay.
Yes, Hadia, thank you.
You are welcome. Okay. Yes. So the management of first stage of labor in breach, I think she has beautifully given us. Chrissy has done very well. Now, okay. Now, observations to be made during the first stage of labor. Don't forget to observe the maternal and fetal condition. I think she said it all. The type of contraction that the woman is having, the duration, the frequency. You have to monitor all those things. And then you have to, I think she said it all. Talking about the lab investigation, she did well by talking about lab investigation. So then the fetal condition, she said it. You try, even the woman, don't forget to hydrate her. She's mentioned it all. I don't think we have to go over this management because we know how to manage first stage of labor. And then the only thing is that regarding the fetal condition, if there's meconium stained lipo, even though it is breech presentation, it should be of concern so that the FH that you are monitoring every 30 minutes, you can be monitoring it every 15 minutes to make sure that the baby doesn't go into hypoxia or the baby is not hypoxic. It's very important. And then if there are other things that you are seeing that is unusual with either the mother or the baby, then you report. You have to report to the obstetrician or the gynecologist or the pediatrician, so that they will take a decision, especially if you are in a well-equipped facility. That's where you get all these professors there. Let them be aware that there is a breech presentation in the woman. We have monitored the first stage of labor, the second stage of labor. You want them to be aware. So let's see the management of breech presentation during the second stage of labor. Who has ever delivered breech before? Hello, please, I want to know your previous knowledge. Breech presentation, breech delivery during the second stage of labor. During the second stage of labor. How do we manage the breech? You have conducted breech delivery before, so please, I want you to share your experiences with us. How did you deliver it? Let's have an idea. Hey, me kind of phone na mobile ball. So we go for my share na. Ade a me dey you say we rebe what? Mon say phone am looking go for. What was about mobile ball car na share? Hello. Hello.
Hi.
Hello. Forgive me. I say what is Zongo so sana bebe. Mo panche me why? They made me to be shouting into your ears. It's good I came out because it's like I've packed my car. They want to play football there. Okay. Oh, please. Afilwa Hassan, how did you manage or conduct the second stage of labor in your
Hello, ma'am.
Can you hear me?
Yes, I can hear you.
Okay.
Actually, I've never conducted. No, ma'am.
You haven't conducted breech delivery before. Hello?
No, please.
Then today
Hello?
I'll teach you. Hello? Hello?
I've never conducted. Hello?
I'm listening to you. Go ahead.
I said I've never conducted a breech delivery before.
Breech delivery before?
No,
okay. Then I'll show you. I'll teach you how to conduct the delivery. Because one day, you can't face to face. Yes, you can't face to face with breech delivery. Delicious. Maufemo. Hey.
Yes, ma'am.
Delicious. I can see your hand up. Go ahead.
Please, I've conducted breech delivery on triplets. So the woman came
Wonderful.
in. She came in the second stage. So she complained she had something in the perineum that was pressing her. So when I positioned her, I realized it was footling. The first foot was out. So I confirmed the dilatation. Then I traced the first foot inside and I realized the other one was flexed upwards. So I had to trace and then bring it down to be able to deliver the other foot.
How did you bring the one that was extended? I mean, traced because that is extended breech.
When I traced inside, I located the back of the knee.
Good.
So I was able to flex the leg at that point. When I was able to flex, I was able to get the foot. So I held on to the foot and then gently brought it out.
Good.
And then when I brought the foot out, I was able to get both legs outside. Maybe because she was pushing, baby was coming, and then the bottles came. I held on to the bottles, bringing out the other body part to the shoulder. So I realized the posterior shoulder was rather coming first. So I did the extension for the posterior to come, and then I brought it downwards to deliver the anterior, and I left to the head. Because it was my first time, I didn't know how to deliver the head. My superior wasn't around. So I was wondering, so I sent my hand inside again. I was able to locate the mouth of the baby. So I quickly put a finger in the mouth to flex the baby's head. So that the chin could keep the perineum. So that was how come I was able to deliver the first twin.
Wonderful.
The second one too came out.
You did well. Because for the first time, in fact, there's always the first time. It's raining heavy over here. Please, it's raining heavy over here. So if I'm shouting, as I teach, if I shout, don't say Ajay is shouting on us. I'm not shouting on anybody. It's because it's raining. I'm thinking that if I don't shout, you people won't hear. So that is it. So that is it. Then close my windows. It's raining heavy. Is it raining at your place too?
It just stopped at my end.
The weather has changed, but it's not raining.
Yes, it's raining.
No, it's not raining.
Okay.
It's not raining.
It's raining.
But we are dying.
It's raining.
In case thunder is striking at your place, you can go off for some time. It's not good for our health.
Okay.
But we can continue.
So what do I do? It's raining heavily. Hey. Let me close my my windows, my doors, and
if it's uncomfortable for you, then we can call it a day.
It's true. Your health is man.
Yeah. Can you hear that it's raining?
Yes.
Yes.
Let's hold on for some time. Please. Let's hold on because the rain is heavy.
Okay,
Why?
man. Okay.
And when it stops, I'll continue because after we have about 45 minutes left. So once it stops, I will continue.
Yes, ma'am.
Yes, ma'am. Just call Sister Genevieve and we'll come back online.
Okay.
Thank you.
Thank you too.
What is the rice?
I just for something in there. The rain is very heavy. It just finished at our area.
Except Hajia is muted.
Okay. So please, let's go through the second stage management of breach presentation. Can we continue? I think we are now 197. Oh, we're more than 300. Okay. But this is a crucial portion that we have reached. Don't worry, I'll video it and send it to you. But let's go through it. Let's go through. Okay. The one who was sharing her experience, thank you very much. At least she enlightened us on there, and she even reminded me of how to do the extended legs of the bridge. And as she rightly said, when the legs are extended, you do V, you feel the popliteal surface of the legs of the baby. That is behind the knee, just behind the knee. You press it. If you're standing there, and even you as an adult, if unawarely somebody presses on your popliteal surface, that's immediately behind your kneecap, you will definitely flex your legs. Automatically, you flex your legs. So it is with the bridge. Okay, so that is just once you press there, baby will flex the legs and then you deliver the legs. But let's go systematically. Okay. Can I continue?
Yes, sister.
Good. So management of breech presentation during the second stage of labor. We are saying that the midwife can deliver an undiagnosed complete breech of a multiparous at the district, meaning that if you are alone at the district, at the rural area, where there's no pediatrician, no obstetrician or gynecologist, you don't try attempting delivering the breech, especially if the head is quite big, if the abdomen is quite big and it is breech. Please refer to the nearest facility where, if possible, they can do CS and remove the baby. Other than that, if the baby is of average size, then we are teaching you how to conduct that delivery wherever you find yourself. Okay. So we are saying that the ideal is, ideally, it should be delivered in a hospital where complications can be managed. Most breech deliveries are managed with CS. That one is true, especially if the baby is post-term or big. I've said it, I've repeated it. If the baby is too big and is breech, it's a post-term baby, the head will not mold, so that after coming head of the breech becomes an issue. So that's why you don't try. If it's a post-term baby with breech, don't try it, madam. Don't try. Send to the highest facility for CS to be done. Then you have to ensure that there's full dilatation of the cervix. Do vaginal examination to ascertain that the cervix is fully dilated, because please listen to me carefully. A multiparous woman may be able to deliver the baby, multiparous woman. But then, what is happening to my mic? You can't hear me? Please, can you hear me?
We can hear you,
Yes,
Adia.
Somebody just put a message there. Somebody's just sent me a message that my mic. There's nothing wrong with it. So, madam, you check your line rather. Check your internet if you can shift yourself somewhere that you can hear. Because I think I can be heard loud and clear. Okay. So, the first thing that the midwife does is to ascertain full dilatation of the cervix. And I was saying that if the head is in a multiparous woman, because she has delivered through the cervix is loose. And so sometimes the body can pass through, but you can never imagine, or you cannot ascertain the size of the fetal head that is left there. And so don't take chances that because she's a multiparous woman, she can deliver. Don't take that chance because you don't know the size of the fetal head. So we are saying that make sure the cervix is fully dilated before you encourage her to push. The smaller buttocks can pass through cervix that has dilated about 8 cm. What about the head? It can pass through. And sometimes they have to do decapitation, cut the baby's body off, leave the head, and still go and do CS. I mean, it's not good. So make sure there's 10 centimeters cervical dilatation before you attempt to deliver the baby. Then the woman should be in the dorsal positions with the knees flexed. Bring her to the edge of the bed. Please don't forget that. If the bed is that, you can separate it. You know, sometimes they have two pieces of bed that they bring together. You separate it, please. If it is breech delivery, separate the bed and let her be on the other half of the bed. Why? Because the baby's body is going to hang on itself to pull the head into the cavity and to the outlet. So if you don't bring the head, the buttocks at the edge, you can't deliver the baby. If the bed is such that you can't separate it, then bring the woman to the edge, very edge of the bed, at the lower part of the bed. That's what I mean. So that the baby, the bodies of the baby can get a place to hang itself. It's very important. Okay, so that is it. Then encourage her. Don't forget to listen to the fetal heartbeat. Ask your assistant to listen to the FH before you deliver a dead baby for the mother. Listen to the FH. Now, FH is positive, baby is bouncing. I mean, the pulse or the FH is bouncing. Don't deliver dead baby for this poor baby woman. because of your ignorance or maybe inability to conduct the breach well. Do the right thing. Then you encourage the woman to bed down after draping her. Where draping means, we all know draping. You get 4 delivery towels, put one on the abdomen, one on each thigh, one under the buttocks of the woman. Then you prepare like the usual preparation for delivery. After confirming that it is second stage, prepare, encourage her that she will push with contraction, but make sure you are well protected. Wear your protective clothing, all right. Then you come and stand there. Tell her, madam, push with contraction. If there's no contraction, let her rest. If there's contraction, let her push with contraction. But to some of the midwives, even when there's no contraction, they say, Mama, chim, chimo, I was so chim. Santi, and yemi, I was say, chim. Hey, it is a contraction that will help her to push. There's no contraction, you say she should push. Go and try it yourself when you see how tired you will be. So that is it. Now, so you continue to encourage the woman to bear down or push. She should be able to expel at least the buttocks without the help from the from the midwife. She will push and you see that the buttocks will come out, the anterior buttocks will curve up, it will restitute. As soon as it is done, you see that the legs will disengage. Then the legs, we are not being worse. The legs will then disengage. But there's this matter. When we say hands-off breach, what is the meaning of it? Please, what is the meaning of hands-off breach? Oh, nobody.
Please, Hajia, it means you shouldn't try pulling the baby.
You shouldn't
try to pull the baby out.
Okay. It means when we say hands-off breach, it doesn't mean you shouldn't handle the breach, but it means don't pull on the breach. Some people, as soon as they see that the legs are out, they start pulling the baby. Don't do that. Please don't do that. So hands-off breach is a maxim. It's like a slogan. It's a maxim. Hands-off breach means that do not pull on the breach because it will encourage premature breathing of the baby, of the fetus, and then it will extend the head. In breech delivery, when the head is extended, there's a different way of delivering the head. If the head is well flexed, there's a different way of delivering the head. So I will teach you all those things. So I'm saying that once we are saying hands-off breech, it means don't pull on the breech. But then as soon as the buttocks and legs are delivered, cover the baby. Cover the part of the baby that is out to prevent chills, to prevent cold. Because once it is exposed to the external environment, baby will feel cold, and baby feels cold, and it will begin to shiver. And in the process of shivering, it will extend the head. It will extend the head. You can try it on a baby that we are sponging. If the baby is sponging, the moment you pour the water, you see, it begins to shake. Like somebody having rigor. It will definitely extend the head. That is what we don't want. Midwives, we are interested in breech delivery that has a well-flexed head. And that is where we use what we call Benz-Marshall method. We use Benz-Marshall method to deliver the after-coming head that is well-flexed. But if it is not well-flexed, if the head is not well-flexed, we use what we call Malicieux-Smellie-Vier method. Malicieux-Smellie-Vier method. Those of you who are feeling sleepy, try to pronounce the word. Everybody should say it. Say it in a chorus form so that you stay awake. I say Malicieux-Smellie-Vier method. One of you is laughing at you. She couldn't pronounce it. Meanwhile, she's laughing at others.
Smelly.
Who is saying my shoe? It's not my shoe. It's not my shoe.
Smelly.
So now you are awake. Everybody is awake. Nobody to say my shoe smelly. It's not that is smelly.
Smelly.
Say it again. Say it.
Malthus-Olivier method.
Okay, Malthus-Olivier method. Okay, so it is used when the head is extended. If you mean actually, why you are laughing, eh? So when the head is extended, that we use that one. Okay, so we are saying that you continue to encourage the woman to push with contractions and rest in between. Now, you have covered the woman, the baby. It's left, ask the woman to push up to the shoulders, up to the elbow. You are going to do vaginal examination. I think that will be the second VE that you do. You do VE first to feel when the baby is born up to the abdomen. Please, let's start from the abdomen. From the abdomen, you do vaginal examination to see if the cord is nipped between the baby's trunk and the undersurface of the symphysis pubis. That is why we are doing the VE. And so if you do the VE and the cord is nipped there, you make what you call a loop of cord. Use your 2 fingers. Then let the fingers, let the cord be in between the 2 fingers. Then you bring the cord gently down to the side of the maternal pelvis, inside the vagina. Gently. Don't use force. Don't exert pressure, else you cause spasms of the cord. So gently do V, hold the cord, bring it down gently in between your 2 examining fingers. That's the index finger and the middle finger. Bring it down to the side so it is not nipped. Circulation can continue. Now, after that, after doing the loop of cord, after making the loop of cord, you ask the woman to continue pushing. Encourage her, madam, you are doing well. Oh, very good. Mommy, why you dear? My mom is some amount. Why you dear? You know, we are chim when you are in pain. Use it to push. Then she will continue to push. As she pushes, the abdomen will be born. Then it's getting closer to the shoulder. Remember, the baby has folded the arms on the chest, and that is for complete breach. So you're going to do a third V. When you do what are you looking for? And why are you doing that V? You are doing that V to feel for the elbow of the baby. I hope we are together. Are we together at this point?
Yes, Hadia.
Yes, follow it. Definitely, I will get you the video. I will get you the video that I will be conducting the delivery for you to see. But get the theoretical aspect first, so that you wouldn't find yourself wanting when you come face to face with what do you call it, breech presentation or breech delivery. So then I'm saying do a third V and feel for the elbow. You yourself bend your elbow, bend one of your elbow, and then when you make an attempt to feel for do vaginal examination, you see that you touch the elbow. Touching the elbow means baby's arms are well flexed and the arms are not extended. If you do V and you touch the axilla of the baby, what does it mean? What does it indicate? What does it denote? Sorry. If you do V, it means what?
It's not well flexed.
It means it's not. If it's not well flexed, it is what?
Extended.
Good. It means the baby has extended the arms. And there's a way that we have to do it, deliver it. If the baby has flexed the arms, hallelujah, the midwife will be happy. It means you can now deliver the shoulders. If the baby has extended the arms, that's where you feel the axilla. And that one, there's a maneuver that you use to deliver the arms, bring the arms down. We call that one love set maneuver. Love set maneuver. It's an obstetrician who he devised it. He said, you splint the upper arm, that is the humerus. You splint the arm of the baby, Then you try to bring the hand down by using the arm of the baby to sweep its face like a cat sweeping its face in the morning. Those of you who are staying with cats, early in the morning when the cat gets up, watch it. We are not there for this. Watch it, learn something from the cat. It will just use the hands to be sweeping, cleaning the face. And so this obstetrician observed that, this method can also be used to sweep the baby's face when the baby's arms are extended up, so that you don't cause fracture, clavicular fracture. Those who don't know this mechanism that I'm talking about, they are the midwives who are causing fracture, breaking the clavicle of the baby because she's forcing the arm to come down. You can't do that. Don't do it anyhow, but use Lafset maneuver. Splint the upper arm, bring the hand down, use it to sweep the baby's face, bring it down, and then you can now deliver the baby. So in Lafset maneuver, there's something we call Lafset clockwise, anti-clockwise. I'm repeating. I'm saying that in Lafset maneuver, there's something we call clockwise, anti-clockwise, meaning that you deliver the baby's anterior shoulder by going clockwise. Remember, we said the baby's abdomen should not face uppermost. So this is how to go about it. Let's deliver the baby's shoulders. Are we together? I'm going to deliver the shoulders of the baby. Now, the sheet that you use to cover the baby, mother has pushed up to the shoulders. You have done VE. You have seen that the shoulders, the arms are folded on the chest. So you have no problem. You can deliver the shoulders. Now, let your thumb be positioned at the sacrum of the baby, whilst the rest of your fingers, I'm talking about both hands, are grabbing the iliac crest of the baby. Now, utambo should be at the sacrum of the baby. That is what I'm trying to say. So, by grasping the waist of the baby, then with downward movement, when you pull the baby down towards the perineum of the mother, the anterior shoulder will be delivered. Now, in the same position, by grasping the waist, lift the baby's waist up, then deliver the posterior shoulder. Once that is done, you leave the baby to hang on its weight, because you are waiting to deliver the head. And so the weight of the baby will bring the head into the cavity and then to the outlet. You are waiting. Now, as you are waiting to see the hairline, the nape of the baby's head. The hairline, you want to see it. So as you wait and the hairline is not appearing, baby is in a prone position. The hairline you are waiting for to tell you that the head is now in the outlet, but it is not coming. You have waited for almost 1 minute. The hairline is not coming. We are not seeing the hairline of the baby. So what you do is you will do 4th VE. Please take note. I'll bring all these things in your objectives. So take note and listen. If there's a question you want to ask me for clarity. Then you are going to do the 4th VE. You see the infection rate of a breech delivery. Do VE and feel for the molar bone. Molar bone or zygomatic bone. You press on the molar bone. It means the head is in the transverse diameter. The baby's head is in the transverse diameter of the pelvic outlet. And that is why you are not seeing the hairline. But what you do is put your hand inside the vagina, press on the molar bone of the baby, and rotate the head. Rotate it. You see it in the video when I demonstrate for you to see. Press, and then you see that the head will now be in the AP diameter of the outlet. Should I repeat it? Hello?
Yes, please.
Yes, please.
Okay. The delivery of the head. I said when the shoulders are delivered, leave the baby to hang on itself to bring the head into the cavity and then to the outlet. You have waited for about 1 to 2 minutes. Some scholars are saying 1 to 2 minutes. Some are saying 1 minute. So in a minute's time, you expect to see the nape, where nape means the hairline around the neck. You expect to see it, but you are not seeing it. It means the head is in the transverse diameter. You, the midwife, will have to rotate the head into the anterior-posterior diameter. So you press on the molar bone. There is the anterior molar bone. The molar bone that is facing the symphysis pubis. Press on it gently. We are rotating the head into the anterior-posterior diameter. Because if the head is in the transverse diameter, it will never, ever come out. But when it is in the AP diameter, it means the face is in the perineum, the occiput is pointing to the symphysis pubis. That one you can deliver the baby easily. So you do that rotation. Then once that is done, and the head is flexed now, so you lift the baby's legs in an even steady traction of 180 degrees. Let your middle finger, please listen, let the middle finger of your left hand be positioned in between the baby's legs. Then the rest of the fingers are grasping the legs of the baby. The middle finger is in the middle of the baby's legs. The rest of the same left hand is grasping the ankle of the baby. Then you are pulling the baby. You are pulling the baby and make sure that the pull is even. So that's what we say, apply an even, steady traction at an angle of 180 degrees. If it is not 180 degrees and you bend the baby, you break the spine. You cause spinal fracture. You will cause spinal fracture of the baby, and baby will be born dead. We don't want to do that. And so the traction should be evenly stretched. And then you see that once you lift at that angle, the face of the baby will appear at the vulva. Then you ask your assistant to suction the baby. Clear the mouth first. Then you clear the nostrils so the baby can breathe. Remember, the circulation is now adult circulation. So baby will have to breathe through the mouth and breathe through the nose. So clear the mouth first, clear the nostrils. Deliver the baby onto the mother's abdomen. That is how it is supposed to be. So that is delivery of the head by what we call Benz-Marshall method. So in an examination, if I should ask you, in a well-flexed head of the bridge, with the arms folded on the chest, what mechanism, what maneuver would you use to deliver the after coming head of the bridge? What will you say? Which one will you choose?
Benz-Marshall.
Yes, you use Benz-Marshall method. Okay. Now let's see when after you are seeing the hairline, but you realize that the baby has extended the head. Probably you forgot to cover the head, the part of the baby that was born. You forgot to cover it. And so baby felt chilled and then it extended the head. That's why you use the Molossus Viet method. That one I will demonstrate when Monday, inshallah. Monday, I will do the demonstration for you too, and then send it as a video to you. In that case, you are only going to use the left hand, the same left hand. You use the left hand, place the baby's abdomen on your left palm. Your left palm is supporting the chest of the baby. Left palm is supporting the chest of the baby. Baby is lying in an astride manner. Where astride means standing, when women, when we are urinating, we stand in an astride manner. You stand and open your legs. That is an astride position. So position the baby on your palm in an astride manner. So that one leg is at the left side, one leg is that way. your palm supporting the chest. Then the middle finger of your left hand will be inside the baby's mouth. The middle finger of your left hand is inside the baby's mouth. Then the ring finger on one shoulder, the pointing finger or index finger on the other shoulder. Then the right hand, middle finger will be pointing to the occiput of the baby. Then the ring finger of your right hand will meet its fellow on the left hand, whilst the pointing finger or the index finger will meet the left pointing finger. Please do that without the baby, and let's see if you have done it. 2 index fingers are meeting, 2 ring fingers are meeting, middle fingers are meeting. Have you done it? Please, have you done it?
Yes, sister.
Hello, I'm communicating to you. Communicate back to me.
Yes,
Have you
sister.
done it?
Yes,
Yes.
sister.
This is exactly the position I'm telling you. But then the baby is in between. So you apply traction on the shoulder. Then the right middle finger is pressing on the occiput of the baby. Is pressing on the occiput of the baby to aid flexion because baby has extended the head. The left middle finger will be in the mouth of the baby, also aiding flexion. So sometimes in an examination, you may be asked, shoulder traction, head flexion is seen in which or is used in which of the following maneuvers? What will you say? Head flexion, shoulder traction is used in which of the following maneuvers in the delivery of the breech? What will you say?
Mauritius.
Mauritius method in an extended head. Good. Mauritius Melivier, Mauritius Melivier. They are all there. Use it. So you use it to deliver the after coming head of the breech when the head is extended. Then you deliver the baby onto the mother's abdomen. So, ladies and gentlemen, then look at the time of delivery, clamp and cut the cord, dab dry baby, and then wrap the baby. If the baby is not crying, you suction, you clear the airway. Meanwhile, remember, there are some complications of breech that we have already mentioned all of them. But Ajia has formulated a song out of the complications. We are left with about 10 minutes. Let me quickly sink, and so that, because there are many, so that in an examination, if you are asked to mention 10 or 15 complications of breech delivery, which I'm going to give to you, sing the song in your head and come out with the complications, and then you get your pass mark and go away. So it goes like this. Please, are you ready? Are you ready? Yes, madam.
Yes.
Okay.
Yes,
So we are now with complications of breech. It goes like this. Complications of breech are made of vesico, vagina, fistula, recto, vagina, fistula, amniotic fluid, embolism, maternal distress, uterine rupture, obstetric shock, third degree tear, infection is there, PPH is there, foot drop is there. All these are for mother. Hello, are we together? Did you hear me?
Yes, sister. That was
Okay.
wow.
Anja, please repeat.
That was wow.
Okay.
If you can repeat again.
Okay. Complications of breech are made of vesico, vagina, fistula, recto, vagina, fistula, amniotic fluid, embolism, maternal distress, uterine rupture, obstetric shock, third degree tear, infection is there, PPH is there, foot drop is there. All these are for mother. Intrauterine hypoxia, intracranial injury, asphyxia after birth, fetal distress, clavicular fracture, nerve injuries, Earth palsy, Kromke palsy, facial palsy. All these are for baby.
Oh, hi, Diana, Miss Wow, wow.
With a
Okay.
standing ovation for Adia One. Instead of the year.
Clap for you.
Wow,
We
it is.
are going for
Clap
teaching level.
Okay, learn the song because I will ask you to write 10 complications of the breach presentation or breach delivery, and then you should be able, once you sing, you will be able to put down all the points. You'll be able to write them down. So that is it. That is all about breach delivery. But please, who will remind me on Monday, inshallah, if God gives us our lives, then I will go to the demonstration room, conduct the delivery on a video, and then send it to you for you to observe all that I'm teaching you. Any question, please, before they take us. So this time, when they are taking us off, they don't remind us. Before we could say Jack, they are taking you off, and then the classes has ended. I am teaching, and somebody else will end my class for you. Well, sure. Anyway, that is part of the teaching. You know. So see, please talk again. Come again.
I said
The song, the song. Oh, but you have the recording. We are recording the teaching. The recording is there. So whoever is doing the recording, please disseminate it to them. I beg you.
Oh, hi, we are enjoying the song.
Thank you. So whoever is doing the, thank you very much. Whoever is doing the recording should try to put it on the page for them to learn it. I beg you. So that I will do the demonstration later. That's how it's supposed to be. But if you have any concern, any question, just bring it up so that I clarify before we draw the curtains for the day. Nadia Mahama, I can see your hand up. Ask your question, dear. Nadia Bama Mahama, your hand is up. I'm waiting for you. Go ahead with your question, my dear.
Okay. Good evening, sister.
Good
Hello.
evening, madam.
Please, my question. Please, my question is not in the breach, but what I have is like, why is it that those women who take like concoctions in labor, when there's cervical dilatation, it doesn't resent with the head descent. They become full while head is still high. I don't know why it happens. I want to know.
How would I even know, madam? Because if the service is, I don't know, that is your observation. Maybe you have to observe.
Most at times.
The head will not come down.
Yes.
But the service is fully dilated.
It's fully dilated.
Don't you think that maybe there's CPD, right? There's CPD, and maybe coincidentally, there has been CPD in them, or all those that you are observing. Is that possibility is there? And so, though the service is fully dilated, the CPD, you know, it can occur at the brim, at the cavity, and the outlet. So probably the CPD is at the brim, where the promontory of the sacrum is projecting too inwardly. And so it's preventing the fetal head from entering the cavity. And that is what will happen. That will cause the cervix to dilate, all right. But where will the baby's head pass to enter the cavity? And that's why the head is so high up there. Or probably the iliopectinal eminence is also projected inwardly, preventing the fetal head from entering in the oblique manner. The babies, they use the sacrocotyloid dimension. The sacrocotyloid dimension, that is the diameter between the ilopectineal eminence and that of the promontory. That is the diameter that the fetus uses to enter the pelvic brim. And so if there's a reduction in that diameter, then of course, cervix will dilate, though it may be associated with prolonged labor. Still, the head will still be high. So that's the explanation that I'll give you. I can tell you. Okay. But most of the time too, if before the head can fit snugly to the cervix, then the head might have come down to the outlet there. So that you do the VE and you see caput succedanum, caput forming all over the place, all over the head. There's caput succedanum. It means there's an obstruction, there's CPD somewhere, even though cervix is applying snugly. But the baby's head cannot come out because of CPD, depending on the level that you find the CPD. Is that okay?
Yes, sister.
Yeah, that is it.
Thank you.
You're welcome, madam. Okay, any other questions? Somebody's hand is up. I can't see the person's face. You can go ahead and ask your question. They may draw the curtain now. Yes, dear.
I wanted to know the gestational age for the external version.
At the 36th week of pregnancy.
36 weeks.
When labor has not set in, yes.
Okay.
Because we said that the breach, most of the time, the breach persists prior to 32nd week of gestation. Before the 32nd week of gestation, you will still get the breach, but that is normal. That is normal. But after the 36 weeks, if it still persists, then that is where we have to take it seriously. I think it is in the notes. I said it.
Aja.
Yes, yeah. Yes, go ahead.
Please, with the
external cephalic version.
I think we also consider the estimated fetal weight before we go on with it.
It is the gestational age that you are dealing with. The weight, unless the scan gives you the estimated gestational, how do you call it, the weight of the baby, you wouldn't know the weight of the baby. You wouldn't be able to tell the weight of the baby unless the scan. It is the scan that will give you. So you don't consider that you are dealing with the gestational age. And as we said from the beginning, and I added it to this very question that the lady asked, that you don't even wait for labor to set in before you do the external cephalic version. If labor sets in, leave it and deliver the baby by the breech. Maybe that is what the baby wants. Deliver it by breech and be on the safer side.
Thank you.
That's why we said after the cephalic, after the version, leave the woman to go home. If she goes home and the breech comes back, then it means there's something blocking the baby's pathway. There's something blocking the birth canal, preventing the baby to bring the head down. And so you did the version and it will turn to breech again. Then you leave the baby like that. You don't try the second time. You don't try. It goes with complications. So if I were you, I wouldn't even try.
Hello, Haja.
Yes, madam.
Yeah, so please, can you confirm scan to can you do scan to confirm after the version is done? That's my first question.
Yes.
Immediately.
Yes.
Okay,
not
then
immediately they say. After immediately after 2 hours, the woman should be in the lying positions. She should be lying still for 2 hours. So after that period, you can still do the scan. You don't want the woman to be moving up and down. Immediately you finish the procedure. No. So after that, you can do this. Yes, dear.
Please, a relative of mine had an experience of that recently at a facility. I don't want to mention the name. The version was done for her. They asked her to go home and come back. So she went for the review. Then labor set in. Then labor started, the progress was not so good. So they prepare her for CS. She went for the CS and she came out with a dead baby.
Oh. What was the indication for the CS? Probably something went wrong. Nobody knows. You know, one of the complications we said true knot. Another complication is it could also be what do you call it? It can cause abruptio placenta. It can cause abruptio. In my life as a midwife, I've tried the external version once, but that one was even oblique lie. Oblique. And I didn't rupture the membranes. I didn't rupture any oblique, you know, turning the baby to longitudinal is easy. So I made an attempt to, you know, turn the baby longitudinal. As to whether it was coming breech or head, it came with cephalic. And so I turned straight and then delivered the baby. And because of the risk associated with it, both the cephalic version or podalic version and then the breech itself, there are complications associated with it. So if the breech is in the second stage, then the baby is not quite big. Me, I would prefer conducting the breech delivery to doing the cephalic. But as midwives, we need to know. We need to know. Because I didn't have any idea at all, with that oblique lie, I wouldn't have been able to turn it into longitudinal lie. I wouldn't have been able, but because I had knowledge about it, I was able to do it, and we had a successful, before even I made an attempt to rupture the second bag of waters. Because my worry is that if I don't turn it to longitudinal lie, then probably she may end up with cord prolapse. With cord prolapse, the first thing that you have to do is to feel for position. If the cord has prolapsed or cord is presenting, feel for cord position. If there's position, it means the baby is alive. Then you can give heavy episiotomy, expedite the delivery, provided she's in second stage of labor. So the first thing that the midwife would do when there's cord prolapse or cord presentation is to do VE. That's the only time that you don't time contraction before doing the VE. If cord prolapse or cord is presenting, you don't time contraction before you do VE. That's why you are permitted to go ahead, do VE to exclude the fact that the baby is alive or dead. If it's alive and it's in the first stage of labor, prepare for immediate emergency cesarean section. If it is cord presentation or cord prolapse. But if you do VE and the woman is in second stage of labor and there's position, my dear, do your midwifery work. Don't wait for the doctor to come and instruct you. Don't let them instruct you left and right. Do the right thing. She's in second stage of labor. Cord is presenting. Cord has prolapsed, my dear. Don't waste time. Make sure you give episiotomy. Don't go and cut through the cord that is prolapsing. Do it with gentility. Give every episiotomy, expedite the delivery, and then rupture the membranes. The membranes are even ruptured. That's why the cord is prolapsing. The membranes have already ruptured, but there's position. So you tell the woman, Madam, push with all your might. You get a live baby. You get a live baby, Shan. So that is it. But if it is in the first stage, cord prolapse, that's why you pass catheter. Please pay attention. That's why you pass catheter, and then you fill the bladder with 500 ml of normal saline. Please, I hope you are getting me. The one whose child is crying, tell your child to stop crying because we are dealing with something that is very important. Tell your child to stop crying. I'm saying that. Please, I'm saying that. Banyuro Roda. But I've put you in the waiting room because what I'm saying is very important to me. So I'm saying that if there's cord pull-ups or cord presentation, there's position, and the woman is in the first stage of labor, I said pass catheter. And instead of after blowing the balloon, fill the catheter, fill the bladder, use normal saline 500 ml, fill the bladder with water, with fluid, with the normal saline, so that when the bladder is full, the uterus will not contract. If there's no contraction of the uterus and the bladder is full, it means there wouldn't be descent, because the bladder and the uterus share the same nerve supply. The bladder and the uterus, they share the same nerve supply. That is the Lee-Frankenhauser's plexus. The Lee-Frankenhauser's plexus supply the bladder and the uterus with nerve supply. So that explains why when your bladder is full and you are in your menses, remember, you go to urinate. After urinating, you see a gush of blood coming out from the uterus. It means the uterus is now getting the nerve supply. Because the bladder was full, the sensation was directed to the bladder. And so uterus was not getting the chance to contract to expel the menstrual flow. Please, I hope you are getting the physiology. So it is with cord presentation and cord pull-ups. If the woman is in the first stage of labor, I'm saying that try to fill the bladder. Fill the bladder with 500 ml of normal saline. So once the bladder is full, it will prevent the uterine contraction. And if there's no contraction, then there will be no descent. If there's no descent, there's no pressure on the cord that is prolapsing to cut off any blood supply. And so you prepare for CS. You get a live video, you get a live mother. That is the whole thing. I've taught you cord presentation, cord prolapse. When I bring it in an examination, don't say Agia didn't teach us. I've taught you. Any question? Any question, please? How
Yes,
how are we?
Mama.
Yes,
please,
yes.
how do you fill the bladder with the normal saline?
Oh, I said when you pass the catheter, normally when we pass catheter, we inflate the balloon. We blow the balloon. Are you aware of that?
Yes, please.
There's a column, two-way column, two-way catheter. One will pass through to go and blow the balloon. So after blowing the balloon, where the urine will pass, where you were expecting urine to pass, you are rather adding fluid to it. To fill the bladder. So as soon as you finish, you cock, you spigot the catheter. You don't connect it to drainage bag. Are you getting it?